Dr. Saffore got his bachelor's degree from MIZ.
VOU.
Okay, thank you. University of Missouri at Columbia. That's how natives say it, I thought. The people I know from Missouri say it like that.
Yes, you're allowed to say it. So.
Maybe. He then got his PharmD degree from UIC College of Pharmacy. Chris joined our program in PSOP after that, where he was a Takeda Health Outcomes Fellow for 2 years. Chris has also received 2 years of funding from ROCI. He's probably got other awards that I'm totally not aware of, but
Martin Luther King Award.
He's got a Martin Luther King Award. Noted because it is Black History Month, which Chris has reminded me of, and he puts up trivia in the grad student office about Black History Month. Today, Chris is going to actually talk about a three-pronged presentation that's going to be given at a large meeting in Atlanta in April called the RX Drug Abuse and Heroin Summit, where keynote speakers in the past have included Bill Clinton, who was it last year?
Obama.
Barack Obama.
Kellyanne was there.
That's who I was thinking of. Kellyanne Conway was there, so some big names. Oh, listen to the crowd. Some big names in politics. Yes. So Chris is giving us an introduction to what he's going to be part of in the RX Summit in April. So, Dr. Saffore, it is all yours.
All right. Thank you, Todd, for that great introduction. Thank you. Hopefully I get the same applause at the end of this presentation. All right, so the actual title of the presentation is Tailored Approaches to Opioid-Related Academic Detailing in Urban and Rural Prescribers. So first, I want to start with some Black history trivia. We were talking about that. So the conference is taking place in Atlanta, Georgia, and actually Carter put up this answer in the office earlier, so I thought it would be applicable for this presentation. Does anyone want to take a stab at it? No?
One of the kings? No?
No, it's okay. So it's going to be it's fine. It's going to be Maynard Jackson. So Maynard Jackson was the first African-American mayor of Atlanta, Georgia. No one would know that. I'm going to say like 70s, like 1973. When I checked Wiki last night, I think it said 1973. Yeah.
Nobody in this room was alive at that point.
Okay, so the learning objectives for this talk are to differentiate between academic detailing strategies in urban and rural areas, explain how provider-specific information can be used to enhance an academic detailing visit, and to identify and address barriers to implementation of key messages of an AD visit. And first, I'd like to begin by acknowledging many collaborators on this project from the Illinois Prescription Monitoring Program, from the Department of Public Health, CDC, Amita Health, which was the institution in the urban region where we delivered the intervention, academic colleagues or academic institutions like SIUE, where we solicited the expertise of pain management specialists, and then our UIC team, Todd Lee, Dr. Simon Picard, I think I did the opposite, and our academic detailing team, through which we could not have done the project with. Mary Smart has been very integral in the project in both areas, urban and rural. So, all right. So for this portion here, just going to give an overview of what is academic detailing and its importance of tailoring the approaches by geographic region. Then I'll go ahead and talk about our detailing initiatives in the urban and rural areas, and then also barriers to implementation of an academic detailing intervention. So what is academic detailing? It's a method of educational outreach, one-on-one, face-to-face encounters with clinicians. It utilizes specially trained personnel such as MDs, PharmDs, and registered nurses, and they go into the office and they're providing current, unbiased, evidence-based information such as clinical practice guidelines to influence some sort of behavior change. And it is effective at improving professional behavior. Specifically, in our case, we're worried about prescribing behavior. So what academic detailing is not, okay? So it's not a didactic lecture, and I hope that I don't do that to you in this presentation in the healthcare provider's office. Written materials sent directly to providers, like leave-behinds. It's not focused on cost savings or limiting industry influence, although academic detailing has another name, maybe known as counter-detailing. and it's not punitive in nature. It is also not Ken Bone. Ken Bone will be the portly gentleman at the bottom. What? He's a little portly. Portly gentleman in the red sweater. And I don't know if you guys kept up with politics, but he went viral. Was a polarizing figure. I don't know if polarizing is the right word, but during he asked a question during one of the elections. So the academic detailing is definitely not him. So examples of where academic detailing has been applied to improve clinician behavior. It's been applied to improve the use of antihypertensives, antimicrobial stewardship, alcohol use disorder treatment, and more specifically in current, or I guess relevant to what we're talking about here, naloxone prescribing and opioid prescribing as it relates to the opioid crisis that we now face. So academic detailing in rural settings, it can be challenging, at least logistically, for our detailers to meet with prescribers, especially if they're located in urban settings. If you can see the map here, this map from the College of Pharmacy all the way down to Marion, Illinois. It's about 330 miles and takes about 5 hours by car to get there. So that's not an easy thing to do. Additionally, a way to mitigate that would be to conduct the visit utilizing some technology-based software. But in rural settings, if they have IT issues or limited capabilities, that may be a problem. So face-to-face interaction may be the only way to go there. And also time and cost prohibitive. So time, you can definitely see it takes a long time to get down there. And then if you want to fly or take a train or car, that's an added expense as well. So the importance of tailoring these programs, geography poses unique challenges when developing these programs. There are things you need to keep in mind, so such as the prescribing patterns in these areas. They may be different. Establishing partnerships is going to be a theme throughout this presentation, that these are crucial to developing and implementing an academic detailing program. Also logistics, travel is the main travel and mode of delivery of the visit, and then also the educational message, which will kind of center around the prescribing patterns in each geographic region. So here is a heat map here of geographic differences and looking at diversion and day supply. So the green map here is going to represent 556 patients, and 556 is a metric that says a patient has a prescription that was dispensed from 5 or more pharmacies, 5 or more prescribers in less than 6 months. So it's kind of a crude measure of diversion. And you can see on the red map here is day supply. So there's more people, or the measure of diversion is higher in the green, in the dark areas, you can see. And you can see that in more urban areas face this issue of diversion, whereas you can see day supply is much more concentrated and highest in the southern region. So it may you may want to target your messages depending on the problem that is in each geographic region. Establishing partnerships, again, crucial. It's essential when developing and implementing AD programs. So in our case, working with the state-based prescription drug monitoring program, state departments of health and human services, local academic institutions, such as Southern Illinois, provider groups and healthcare systems, and also the National Resource Center for Academic Detailing. They're able to provide guidance on, just the simple things to do and not to do regarding as it relates to academic detailing. So logistics. So in the urban setting, travel options for detailers, you may use a car or public transportation. I myself don't take public transportation, so I would drive everywhere. Whereas for in the rural setting, car, train, or flight. Car, we know, is going to take a long time, at least if you're driving to the southern part of Illinois. Train or flight. So these are things that you need to think about when developing the program. Length of travel. I was thinking about this last night when I said minutes, and depending on what time you're traveling in the city and where you live, it could take you an hour, sometime due to traffic. But length of travel, definitely hours if you're driving to southern Illinois, no doubt about it. Trip duration. When a visit is scheduled, if a visit is scheduled at 9 a.m., you can get there a half hour before the visit takes place. The visit is over in 30 minutes, and you're done with your day, a partial day, you're done. Whereas for in the rural setting, you may have to get down there a day ahead. You may have to go to your hotel, check in, and then be ready to go the next day. So it may take multiple days, whereas only a part of your day is taken up in the urban setting. Confirmation of AD visits. So at least in our experience in the urban setting, we may have done this maybe 1 to 2 days prior to ensure that the visit was still taking place. But in the rural setting, due to travel and wanting to, once we book things, they may be not refundable. So when we book travel, we want to make sure that the visit is still taking place when we scheduled it. And then also mode of delivery. In the urban setting, we conducted both visits face-to-face. But in the southern region, the first visit is face-to-face. And to get around the logistics that I talked about earlier that were challenging, we're using a technology-based second visit and using WebEx. Okay, so the content and delivery, you want to tailor the content for the setting. So in those heat maps I showed above, you may want to talk to them about utilizing the prescription monitoring program to identify, diversion also in the urban setting, and then also day supply. All these things are captured in the prescription monitoring program and can be points that you talk about with providers to encourage their use of it, to encourage their use. Also, the setting may dictate content delivery. So if it's cancer screenings, they may be better facilitated if it's a provider or a doctor to another doctor. Opioid prescribing, that may be conducive for a pharmacist to go in, and then also nursing home care. A nurse may be better suited to do that. But it is resource dependent. So we're in the College of Pharmacy, and we only have pharmacy students or clinical pharmacists. Then we're going to use clinical pharmacists to talk about all of these things. They just need to be adequately trained on the high points when they're delivering the visit with the physician. Okay, so now I'm going to switch and talk about the detailing initiatives in the urban and rural settings. So first, just talk about the initiatives in Illinois, in both settings, and then really highlight how the provider-specific information can be used to enhance the AD visit. So we have this Prevention for States program. It's a program funded by the CDC. Its goal is to help states combat the opioid epidemic, and they have these 4 pillars here that you can see: prescription drug monitoring programs, enhancing those, community-insured health system interventions, evaluating state policies, and rapid response projects. And Illinois is one of the states currently funded. So the Illinois PFS strategies are taking a 2-pronged approach. One is enhancing and maximizing PDMPs and a host of sub-aims, and then implementing community or health system interventions. And really, academic detailing lends itself to the bottom point there that's highlighted by the box. So here is a map here of just the population density in Illinois. And you can see that dark red area is where we are currently. And as it gets more and more green, it's less densely populated. So we have 2 areas. We have urban and rural, Chicagoland and Southern Illinois. Partnerships, again, very, very crucial to establish. We established those with the ILPM, the Illinois Prescription Monitoring Program, and also the Department of Human Services. And the educational messages for this program centered around safe and appropriate opioid prescribing practices. So our target setting in the urban region was a large health system in the Chicagoland area. In the rural setting, as things are more sparsely spread out, we have many small provider practices, and also still health systems are included too. These health systems reside in the 30 most, ideally would like to reside in the southernmost 31 counties in Illinois, which makes up the Delta region. However, if there are challenges scheduling and identifying providers, we may need to move a little bit more north above that region. The program centers around primary care provider specialties, and these include internal, general, family medicine specialties, and also licensed healthcare professionals with prescriptive authority. And these would be our physicians, MDs, and DOs, and our mid-level providers, nurse practitioners, and physician assistants. So our detailers, first and second year pharmacy students were utilized in the urban region, and 2 graduate students, Mary and myself. when interviewing these students and selecting students that we wanted to be a part of our team, having a vehicle was imperative to have. Just we didn't want them to rely on travel using public transportation. So that was one of the required criteria to participate as a detailer. In the rural setting, however, it's a little bit different. We're using clinical pharmacists, pharmacists actually at UIC that work both in the Drug Information Center, and they're also on the east side of campus as well. And these pharmacists needed to be willing and able to travel to Southern Illinois by whatever mode of transportation, which most of them have been willing to do. So both these groups of detailers needed to integrate these academic detailing visits into both their summer schedules, as is relevant to the students, and also their work schedules for the pharmacists. And the detailers were trained based on the NARCAD model. So when I say that, the core research team, Drs. Lee, Picard, myself, and Dr. Smart, went to Boston. We received training, 2-day training, by the experts at NARCAD about academic detailing. So we took those points, we developed our own, synthesized our own materials, and we trained both detailers using those materials to have an effective academic detailing visit with the providers. So our intervention, it was at least in the urban setting, it was conducted from June to September of last year. It consisted of 2 visits. They're about 15-30 minutes apiece, one-on-one, and they were face-to-face in the frontline clinician's office. A repeat visit was done about 6 to 8 weeks after the initial visit. And one thing of note is that technology-based second visits will be done via WebEx in the rural setting. So the components of the visit included the CDC's guideline for prescribing opioids for chronic pain. We reviewed individual provider metrics, and we call them dashboard metrics. We also administered a satisfaction survey to the providers at the conclusion of each visit. And additional resources were provided as needed as the conversation went with the providers, and included things such as the prescription monitoring program informational brochure to provide any additional information that providers were curious about that maybe the detailer didn't have time to get through, or they just wanted more information. And also the standardized procedure regarding naloxone. Essentially, there's a standing order for it. It's just like a flu shot. If you wanted to, you don't have to get a prescription for it. If you want to go to the pharmacy, you can obtain it directly from the pharmacy. So the format of the visit, it's simple, just like this. So there's a general welcome and greeting. Hi, how are you? The important part prior to starting the visit is having them sign the informed consent. Well, once that is signed and they understand the study, we would go ahead and conduct the academic detailing visit, go through each of the components as time allowed. At the end of the visit, one thing that was stressed and highly encouraged of our detailers was to administer the provider satisfaction survey and to secure that. So if providers said, I only had 4 minutes to meet with you, you do the visit for 3 minutes and you leave that last minute to get that survey. We really wanted providers to fill out that survey so we'd have surveys collected for each of the providers that we saw. After the satisfaction survey was completed, the detailer would end the visit, schedule the follow-up visit with the clinic manager or office staff, and then comprehensively document the encounter via film. Okay, so there's 12. It looks a little weird. I didn't want it to come out this way, but there's 12 total. Key messages from the CDC's guideline, and the ones highlighted in red are the ones that we selected to put in as a part of our intervention. So, number 1, opioids are not first-line therapy. Using the lowest effective dose, strategies to mitigate risk. Review the PDMP, Prescription Drug Monitoring Program data, avoid co-prescribing of opioids and benzodiazepines, and offer treatment for opioid use disorder. So here I just want to show an illustration of what our materials look like. For number 1, review the PDMP. So here we just had points as it relates to how often you should check it. As of January 1st of last year, 2018, there was mandatory registration. So we want to let them know if you hadn't registered by June or August, whenever we saw you, that you need to be registered per the legislation. So this is kind of how we went about illustrating the material to them. Next, and this will be the last one, avoiding co-prescribing. So we really want to illustrate or talk to them about the fatal overdose and CNS respiratory depression. and illustrate this to them. So, okay. So provider-specific information, how we utilize this audit and feedback, it's a widely used strategy to motivate behavior change. So due to that partnership that we have with the ILPMP, we're able to obtain individual prescribing data. So after we obtain this data, we're able to generate some metrics, dashboard metrics, and we're able to share that, give it to the detailer so that they can share that with the providers on each of their visits. So here is what an example of what the metrics look like. So it was a 6-month comparison from November 2017 to April 2018, and each provider, there were 3 columns. Each provider had their own prescribing metrics, and they were compared to all the other primary care providers, and then all other providers from Cook County, unadjusted for specialty. So it was a really crude measure, at least when we got the data at a county level. Metrics displayed at visit 1 were opioid prescriptions by MME per day. So the categories for MMEs, and MMEs are morphine milligram equivalents, is a way to standardize opioid medications. So less than 50 to 89, and then greater than or equal to 90 were the 3 categories there. Next were average monthly number of opioid prescriptions, and also the average number of monthly queries to the actual prescription monitoring program. It's just a measure to see if they're using the database. Metrics presented on the second visit were average daily MME per opioid RX, average daily supply per opioid RX, and the average monthly number of patients that were co-prescribed opioids and benzodiazepines. And the way that they measure that is if you receive an opioid prescription or you're dispensed an opioid prescription and a benzodiazepine prescription within that calendar month from the same prescriber, they count that as co-prescribing. So it's a very crude measure of co-prescribing that the ILPMP uses. So to talk about the survey that is administered at the end of the visit, so it was created for the provider to give feedback, to provide a measure of quality assurance about the detailer, the intervention, and also the impact of the academic detailing on their practice. So we utilize this in both urban and rural settings. So these are the 10 items of the measure, and I just want to highlight a couple of these. So the percentages reference to, and I should take a step back. I was going to do this. So the response scale for the survey was not at all, slightly, moderately, very, or extremely. So these percentages represent providers who indicated very or extremely on the survey. So as a measure to understand how our detailers were performing, we had these items in here that related to the detailer's knowledge and also were they an effective communicator. And we have greater than 90% of the providers indicating that our detailers were very or extremely knowledgeable and effectively communicated the information. Next, we had greater than 80% of providers said they would be very or extremely receptive to future visits, which is a big deal with academic detailing because it is about relationship building and having a sustained relationship. So, but one thing that we noticed was practice likely to change. So about 55% of providers indicated they were very or likely to change their practice as a result of the visit. Here are just some statistics of the urban region. So we saw 186 providers. The breakdown is about the same in both visits for male and female. It was mainly physicians, a small proportion of mid-level providers. We did lose a few residents going from visit 1 to visit 2. That's likely because residents graduated and moved on to bigger and brighter things. Years of practice, about 15 years, and then the scores were relatively high. So the maximum score was 50. They were generally high in the first visit and a little bit higher in the second visit. So we saw we got a response rate of 82%, and we were able to see 85% of the people we saw in visit 1. So we chalked that up as a success in our book. So another, how provider satisfaction is collected in other academic detailing studies. People may just leave the survey behind. They may send a survey monkey. They may use other methods to where they don't collect that information right at the visit. So in lieu of that, we created a detailer perception, a detailer survey that understands their perception of the visit. So we want the detailer to give a account or some feedback about the provider, the intervention, and also how they think the intervention will impact the provider's practice. So this could be used as a proxy measure to understand the visit's effectiveness if we don't have it directly from the physician themselves. And this was also utilized in both interventions. And here are the 6 items that were used in that measure. And I just want to highlight 2 points here. Again, the percentages represent very or extremely that the detailer indicated. So the detailer greater than 80% indicated that the conversation went very or extremely smoothly. And also at the bottom here is a little bit lower for willingness to change their practice. Detailers, about 35% of our detailers felt that providers were very or extremely willing to change their practice as a result of the visit. Okay, so now I'm going to switch and talk about the barriers that we encountered in both the urban and rural settings. All right. So and talk about identifying barriers from providers in the urban setting and also how we address them in the urban setting, challenges and solutions to implementation, especially in the rural setting, and then take-home points for AD program success. So these visits, they were documented as a part of the format of the visit. They were documented by the detailers immediately after the visit concluded through field notes. So we conducted a thematic analysis of those field notes to identify themes that are related to barriers to prescribing, specifically related to opioids. These themes were generated from open-ended questions and feedback from the providers. So providers weren't directly asked, what barriers do you face to prescribing opioids and managing patients with pain? They weren't asked that question. And that's something that we refined for the southern region. That question is now being explicitly asked and obtaining that information from providers. So you live and you learn. So these are the themes of barriers that were identified from providers. So beliefs, knowledge, health system, patients, and the prescription monitoring program, okay? So beginning with beliefs. Providers indicated to us that, sometimes they didn't believe in the opioid epidemic or the source of the opioid epidemic. Maybe they think it's the government's fault. They also didn't think the opioid epidemic affected their practice or their patients. And then some providers indicated personal experiences may affect their beliefs on opioid prescribing. As it relates to knowledge, providers were unaware of non-opioid alternatives specifically for certain conditions such as hepatic or renal insufficiency. What drugs do I use in those patients? Some providers indicated knowledge gaps around opioid medications. Are hydrocodone and Tylenol 3 the same thing? I don't think so, but those were things that they indicated that they were unsure about. Naloxone affordability and access. They were unaware just of the cost based on the patient's insurance, a ballpark of how much it would be, and access. They were, some providers indicated, I have to write a prescription for this, and through providing them information about the standing order, we were able to fill in that knowledge gap about the access of naloxone. Additionally, awareness of their individual controlled substance prescribing habits. So this is a teaching hospital, and there were residents there, and if resident physicians felt that opioid was warranted, that opioid was prescribed under the attending physician's DEA number. So when we present the dashboard metrics to providers and they're shocked at what their numbers look like, they think it's higher than what they actually prescribed, they're not taking into account the opioid prescriptions that are included from their resident physicians in that number as well. Health system. So lack of mid-level practitioner empowerment. So one provider indicated that if I have a patient that's been on opioids for a long time, specifically, who am I as a mid-level provider to tell them that they can't have their opioids? So maybe there's some power dynamics to where the provider doesn't feel that they can say no, essentially. Clarity on internal pain management practices. So a lot of providers indicated, well, when is tramadol warranted? When is Lyrica warranted? When does the health system want me to prescribe these things? So there was lack of clarity around that. And then time to conduct a full pain assessment. The providers indicated that they have to crunch so many patients into one day. They don't have adequate time to fully assess the source of the pain and safely and appropriately prescribe pain medication or opioids, what have you. Patients. So some patients it was difficult for them to accommodate their requests for new opioid prescriptions because some physicians had inherited patients from other physicians, and those physicians just kept them stocked on opioid medications. And when these patients get shuffled to new providers, a new provider assesses their pain, and they may not feel comfortable with prescribing a new opioid prescription. So accommodating patient requests was kind of an issue. Lack of affordability of non-opioid alternatives. Now, Voltaren gel, lidocaine patches, at least in some of my time working as a retail pharmacist, some of those things are either not covered or they're really expensive, but the Norco is no charge. So it puts the provider in an awkward spot of, well, I need to treat this pain. Other medications that I would use that aren't as addicting are expensive or aren't covered, but the Percocet is covered. So that was an issue that was frustrating for providers. And variability of insurance acceptance. So some of the clinics in the health system varied in their acceptance of certain insurances, such as Medicaid. So that would put them in a bind because the provider does not want to chronically manage that patient's pain. They want them to go to a pain specialist. But that patient is unable to go to the pain specialist because they don't take their insurance. So that was another issue that they expressed related to patients. And the prescription drug monitoring program. So providers indicated, I just don't have time to do this. I don't have time to do a full pain assessment. I don't have time to check the PDMP. I don't have time to do any of this. And related to that, lack of use. One provider stated that I don't use it because I don't have time. So explicitly stating he's not going to use it because time doesn't allow for it. Providers did say that if usability of the PMP was better, such as integration into their electronic medical record, instead of having to, I log out of this PowerPoint, I have to open up another tab, I have to go into my UIC email. You have to go into all these other different steps to log in. So making PDMPs more usable, and that's one of the pillars of the PFS Prevention for States part of their program. And also registration and password difficulties. So as I mentioned, January 1st of 2018, providers were mandated to have a log on or to register to use the PMP. So when we saw some providers, they had not registered yet, and it's because of difficulties that they faced. So how we address these barriers. So after doing the first visit, there's a lot of data that we had, and we were able to synthesize that, go through it, and understand what the issues were. And the details will indicate in their field notes that, hey, Dr. John Smith, he can't log on to the PMP. He's called them, password reset's not working. So due to the established partnership that I said was really, really crucial with the PMP, we're able to facilitate issues being fixed. And the PMP, we would give the PMP their contact information. They would resolve the issue, and they would directly contact the provider. So on our second visit, we would be prompted to ask, was this issue fixed? And the provider would say, yes, they were. They emailed me, they called me. Thank you for doing that. So, that's how we try to address that barrier. So providers can use the PMP for all the good things that it provides. Naloxone affordability and access. We developed a table, and I don't have it in here, I'm sorry, but we developed a table of different insurances such as commercial, Medicare, Medicaid, and out-of-pocket costs for both formulations of naloxone, whether it's the nasal spray or the auto-injector. Additionally, we also provided patient support program forms for the providers to fill out, at least for the auto-injector, because that one is more expensive. Although I think it's cheaper now, but it's still more expensive than the nasal spray. Internal health system outpatient pain management centers were given to the detailers to disseminate to providers on the second visit. So this apparently is not aware, everyone's not aware of the locations of the outpatient pain management center. So we were tasked to provide this information to clinicians on the second visit. And also some patient-facing material, and that's this document here, how to use naloxone and prevent overdose. Really goes through all the formulations of naloxone, the vial, the nasal spray, the injector, how to use it for layperson use. And I think it also goes through opioids and the categories that they fall in. So to highlight the value-added service that academic detailing provides, the detailers documented the encounter comprehensively. And through that, we were able to understand specific questions or common questions that continue to come up from these providers. So by documenting it, coming up with a list of all of these questions, we sent them off to the chief medical officer and the head pain specialist over at the health system that we worked with. And it was up to them to do with it as they please. Grateful for them, they responded with this document here, and they provided responses to these frequently asked questions that primary care providers had. So it just demonstrates, in addition to academic detailing, providing education on clinical guidelines and such, we're able to hopefully, help improve patient outcomes, help improve systems and policies within the health system. And that wasn't really, the goal here, but we're able to demonstrate the value-added service that our academic detailing program provides. Okay, so challenges to AD implementation. So this is going to be challenges that are faced specifically in the rural setting. So provider engagement, establishing partnerships, again, very crucial, scheduling of the visit, and then how the visit is delivered. All right, so Mary, you correct me if I say anything wrong here. So cold calling or sending unsolicited emails. Essentially, these things failed. Calling these clinic sites, identifying them. In the urban region, we have a certain area we want to go. So I think we use WebMD and use zip codes to identify providers and clinic sites. So we have a whole list of contact information. Now we take our detailers or pharmacy students and we have them call and try to set up these visits. So, someone's calling you. Half the time I don't answer my phone if I don't know who's calling me. So we're lucky that it was a clinic that, they kind of have to answer because I don't think they have caller ID. But there was not a lot of willingness to participate because, what is this program? What are you talking about? You're just calling. I don't know who you are. So cold calls were an issue. And also unsolicited emails. Very low response to emails, if any at all. So that was an issue immediately from trying to schedule visits and get our program implemented in the southern region. Secondly, identifying proper personnel. So when you're calling, the secretaries are the first person you're going to talk to, and you need to get routed to the right person. So these people are not, scheduling is out of their scope. So we're talking, say, hey, and they're listening to us, and they're talking to us and say, yeah, this is something I'd be interested in. And you go to schedule a visit, I don't say wasted all that time, but you need to be routed to the right person in order to schedule the academic detailing visit. So it may be best to work with the office managers or clinic managers, people who know the provider schedules and are able to schedule and are able to put you down for a visit. And last but not least, persistence is key. You may need to repeatedly contact these provider groups or health systems. Not every day; they get annoying, but maybe once a week or once every 2 weeks. To try to get through to them in order to schedule visits. I'll just speak anecdotally for one experience. We were trying to get the Southern Illinois region going, and we had identified one health system to work with, and things didn't work out. To engage with them at that point in time. So we went to the NARCAT conference earlier this year in Boston to really just understand more about how are you guys all across the country and Canada implementing these programs in more spread out rural settings. So we've talked to a lot of people. And one thing was the practice-based research network, and I had never heard of this. And they said, you utilize that and identify people to work with. So I get on Google and I go to this website and I look for health systems that are in the Southern Illinois area. And, I find someone to contact. It wasn't the chief medical officer, but it was someone who works closely with him. So contact them, send them an email, set up a phone call, and from that, we were able to finally get in with the chief medical officer, and, the rest is history. Now we have set up or developed a relationship with them and are able to schedule visits. So you just have to be, persistent when you're trying to implement an AD program. So another way to encourage engagement, especially in the Southern Illinois region, is advertisement and promotion. So you can see by this graphic here, it really shows what we did up north on a large setting, how many providers we saw, how many we were able to see again, what the providers said about the program, and then also the value-added service that we provided. I go back to the FAQ document that was developed for providers. So really just talking about our efforts, sending this, emailing this as an attachment, faxing it, whatever it takes, to these health sites or health systems to really show that we know what we're doing, and we would provide you guys a great service by if you choose to partner with us. So getting your foot in the door, that's half the battle here. So when scheduling AD visits, once we've done that, once we've established our partnership, so we went through above with our advertising and promotion to really solidify that partnership. So after doing that, we're able to get the contact information from the health system of all their clinic sites that they have, and we're able to utilize our detailers or pharmacy students to schedule these initial visits. Now, in the Southern Illinois region, and Mary brought this to my attention recently, email may be slow or their tech capabilities may be limited. So you may need to fax things, which I wasn't aware of that, but you have to do anything, by any means necessary. So some of these providers may want additional information. So if you want to fax them either, a description of the study or the informed consent, we would do that via fax to, further engage them and encourage them to participate in the study. And lastly, when calling, once the health system has said, hey, yeah, this is great, it sounds good, go ahead and do this. When calling and setting up these visits, the detailers are encouraged to clearly state that the health system leadership is aware that UIC is coming in and wanting to do this program, and also that they support us being there. And the difference is night and day from clinic managers, secretaries, willing to participate and engage with us once they know that the health system is on board. So mode of delivery. So this goes back to logistics. These rural settings, they're spread out and they're far away, at least from Chicago. So we decided to use a technology-based second visit using WebEx software, which has somewhat worked out well so far, hit or miss. So if they're unable to use the technology, or if there's issues, there's limited capabilities, you can conduct the visit by phone. But what may be an issue if it's conducted by phone is that they may not be in an area or in an environment where distractions are minimal. Because we want to still conduct the same type of visit. It's just conducted, through software or via the phone. So we still go over the same materials. We still would like them to complete a survey, although that'll be sent electronically. So, it would be preferred if you're not at home watching your kids or the cat holding like one baby and walking around trying to listen to us talk to you, or in the car. We want you to be somewhere, maybe your office or even home office, just to minimize the distractions when conducting the visit. So some take-home points for success. So establishing partnerships are crucial. Without working with the Illinois Prescription Monitoring Program, we could not have developed dashboard metrics. We could not have shown providers how they prescribe relative to other prescribers. We could not have fixed IOPMP issues, login and registration issues, had we not partnered with them. They still owe me data for my dissertation, but it's fine. It's okay. Access to clinicians is half the battle. Once you get your foot in the door, we're able to schedule visits and it's no problem. Letting the office managers know when we're calling to just say, hey, Dr. Ross, Chief Medical Officer over at SIHF, he should have sent you out an email communication. Dr. Saffore and Picard, we spoke at a family medicine meeting and we described the study in detail to you. You guys said that you would be willing to participate. Does that ring any bells? Things like that. So gaining access to the providers is half the battle. The content, developing and tailoring the content based on the setting. So in the southern region, we have this thing called the Holy Trinity, right, which comprises of opioids, soma, which is a Schedule IV muscle relaxant, and benzodiazepines. So those taken in combination can cause CNS depression, respiratory depression, increased risk for overdose, etc. So that may not be something that is talked about much here in the urban region, where it's not much of a problem, but it's more of a problem down there as well. So you just have to tailor the content based on the setting. Ensure your personnel are adequately trained to deliver the content. So we have limited resources. We have pharmacy students that we use, and we have pharmacists. So I talked about different settings such as cancer screenings or nursing home care. As a pharmacist, I don't know very much about that. But if I were to go talk to a clinician about it, I would study up on it. We would develop some sort of content, high points. We may bring in collaborators from academic institutions that we partnered with to solidify knowledge gaps that we have so that we can deliver an effective intervention when we conduct the visits. And lastly, to have a team, or a Mary that's helped me so much, to manage logistics and operational tasks. It takes a village to do all of this. So to make sure 10 pharmacy students make sure they they want to get paid on time for their mileage. Make sure that they know where they're going. So make things easy in the Google invite that you send them, that it has the location of where they're traveling, and having really good people to work with as well. For the pharmacists, scheduling their travel, their flight, train, car ride, enterprise. What's the policies around that? So really understanding everything from a logistics standpoint, not only related to the visit, but the people that you're managing to conduct the visit. And in summary, so improving opioid prescribing practices, it's going to take a multifaceted approach. Me just going and talking to doctors about these are 12 points that you need to use, or these are recommendations that you should keep in mind when you're prescribing opioids. There's more that needs to take place, such as state and federal legislative efforts, which include in our state already mandatory PMP registration. And what is new as of January 1st of this year is continuing medical education for opioid prescribing, which is 3 credits, or 3 credits in total that they need. So as a part of the academic detailing intervention and a value added that we can provide, we can incorporate continuing medical education as a part of our visit. And if it's a 2-part visit, let's just say we provide 1 credit in total, half a credit for the first visit, half a credit for the second. A provider knocks out 1/3 of their requirement for the year, just based on listening to us talk and educate them about prescribing guidelines, and additionally helping them if they have any issues as it relates to the PMP, or they need further education about clinical use of naloxone or affordability of naloxone. So really trying to sell ourselves there. So the academic detailing, it can help uptake these evidence-based recommendations. That's where it is solidified from, and encourage these legislative efforts. And I'll just wrap up on this, due to the differences in the prescribing patterns in the different regions, it highlights a need for tailored approaches to academic detailing interventions. And I'm done. Any questions? Yes.
Is that CE requirement?
No, I think it's just for licensed prescribers.
Okay. My next question, so you said that you had some differences in results with advanced practice providers versus physicians as far as empowerment?
So that was something that was stated, that was documented in the field notes by one of our detailers, yes. Yeah, so we're blinded to any sort of characteristic of the healthcare provider, and as a part of the documentation by the detailer, I guess she verbalized that due to her being a mid-level provider, this patient has had a long-standing history with opioids. Who am I as a nurse practitioner or a PA to tell this patient that they can't have their monthly opioid prescription? So, yeah. Yes, Seema.
On average, how much time does a provider give to devote to the study?
So what was the average visit length?
Yeah.
It was
4 minutes usually, 3 minutes for.
Right. So that's an extreme. That's an extreme. But on average, they were about 15 minutes, and for the first visit, and they were a little bit shorter during the second visit, just because there was different material that we wanted to cover, and we didn't need to sign informed consent. We didn't need to do so long of an introduction, so that kind of cut down the time. Any questions? You guys look eager to ask. Yes.
So I just want to make sure I understood. So you had data, prescribing data on the providers themselves,
Yes.
and that's what you presented in that dashboard?
Yes, their individual prescribing metrics it was a 6-month comparison of their prescribing compared to their other primary care providers at that health system, and then all other Cook County providers unadjusted for specialty.
And this is prior to your visit?
Exactly. So our visits were conducted from June 2018 to September. The data that we used to show them was from November 2017 up until April 2018, so 6-month span.
So is there any data after the visit to see if their prescribing practices changed?
Yes, that's my dissertation. Yes. and a report that we will send to the CDC and the AMITA. So yeah, we will evaluate that. Exactly. Yes. Yes, Seema.
Okay, so you said that in the academic sector, where you're and they, and the residents would, use their attending PDA?
Yes. Mm-hmm.
Is there a way to pull those out?
No, because the DEA that it goes under will be that position. There's no way to disentangle that because it does, because a lot of the resident physicians they have hospital DEAs, and that suffix we're not able to disentangle those last 4 digits after the DEA number are all go to that hospital. So in order to, when they write that prescription, it has to be the attending physician's DEA that goes on it. Any other questions? Yes, Bob.
I do have a question about its application, like outside of the research setting.
Sure.
Because I'm assuming these detailers, they're gonna have like PharmDs or some other highly professional degree, and their time is very valuable.
Yeah.
So how would you actually pay or have an operation where a pharmacist is getting compensated outside of the research setting?
And are you saying still conduct doing academic detailing?
Yeah.
Okay.
Exactly.
So the VA has a good model with academic detailers. Actually, I was looking at a job posting the other day in Georgia, no doubt, to have a full-time pharmacist be an academic detailer within the VAs in the surrounding areas in Georgia. So there are carved out roles for pharmacists, and in this case, the role was for a pharmacist to specifically, that is their role, to do things that are related to academic detailing, identifying the most current literature, synthesizing it into a bifold document or a pamphlet, some sort of visual aid to show to the prescribers based on whatever, if it's smoking cessation, big thing in the VA, COPD, whatever it is for the physicians in that health system. So that's something that they have published a lot on and are really known for. Lisa? No? Okay. Yep.
Thanks, Chris.
Yep.